So it looks like people are coming on, people that I emailed. So I apologize that the wrong link was sent out in the announcement. So Jackie just sent out the corrected link. Hopefully more people can join us. And again, I apologize about that, but we welcome everyone. I see Dr. Burns is here, and he is going to be our presenter today. We're really looking forward to that. So I'm going to go ahead and get started, just given the delay that we've had. I'm Rachel Pets. I'm one of the co-chairs for the SIG, and we're happy you all join us for the first meeting of the year. Some of you have been here before, some are new. So if you don't mind putting in the chat, just introducing yourself, who you are, where you come from, your role at your organization, so we can kind of get to know who's joined us today. For those of you who are new or maybe some of those who've been here before, since it's beginning of year, I thought it'd be good to just go over what to expect at the SIG meetings, just kind of the different agenda items. So we typically start out with announcements, of which we will have a few today. Another thing that we're starting new this year is something called Member Spotlight. We've found that we've grown as a SIG in the past few years, and it's wonderful to see new faces each of our meetings. The downside to that ends up being that we don't always get to know some of our members quite as well and who joins us. So to alleviate that a bit, we're implementing something new where we really just want to get to know our members and ask them to do a brief introduction of themselves, the work they're doing, what they get from the SIG, what they hope to get from the SIG. So today, Amelia, Jonathan, and I are going to do the member spotlight. So we'll introduce ourselves as current leadership. What we'll hope to do moving forward is to get 2 to 3 people to do it each time. It's very low stakes. So if you're interested, please reach out to Amelia. Otherwise, Amelia might reach out to you and ask you to do it at the next meeting, so we can get to know you and the wonderful work that everyone is doing. So other agenda items, after that we'll do Research Corner. Jonathan Larson is our research lead. He always presents an article. It's usually related to our topic of our presenter. And that is the next piece, our This Is How We Do It segment. And today we have Dr. Austin Burns from Nationwide Children's Hospital. And he's going to speak on ADHD care and primary care. So we have a presenter. They come in, kind of present a little bit more in depth about what they're doing in their setting. And then afterwards, we have a facilitated discussion with the group, comments, questions that people have about the topic. So that's our overview today. And it looks like more people have been joining as I've been talking, which is great. And people are introducing themselves, also great. So let's move into our announcements. And those of you who just joined, if you don't mind introducing yourself in the chat of where you're at and where you come from.
All right, while you do that, Rachel, I can give the update on the elections.
Sure.
I'm Maria Rojo, also called Choose, and I have been the co-chair with Rachel and getting out of this role. So unfortunately, there was a glitch with our election. Something happened with the system and that did not register all the candidates. And due to that and for all the good reasons, we are repeating the elections. Unfortunately, that's going to create some, longer wait, and also what it comes with having to repeat it, and both for the candidates and for you guys who are voting. So our apologies for that. Please bear with us while we repeat it. We are going to give 2 weeks time, like we did the first time, just to be equitable and have our 3 candidates listed this time. And hopefully today, Leanne is going to have that ready in the listserv, in the website, so you can all start voting. And again, apologies and forgive us. And we hope to have a wonderful SIG this year. So you forgive all that and stay with us for the year. So thank you.
Thanks, Chus. Yes, and we're hoping that we will have our new leadership announced at our next meeting, which will be February 5th, the first Monday. The only other announcement would be a reminder that as a SIG, we actually facilitate mentorship as a group. So anything related to pediatric integrated care as it pertains to research or practice, administration, training, things like that. If you're interested in being mentored, or if you would like to be a mentor, please reach out to me and we can help facilitate that. And we already asked about job announcements earlier, but I'll just reiterate that for those who just came. If you have any job announcements to share with the group, please feel free in the chat. Okay, so now we'll move on to member spotlight. As I mentioned, it's our way to kind of introduce ourselves as a group. And so I'm going to go first, and then we'll have Amelia and Jonathan go, and we'll just kind of talk a little bit about ourselves and what we do. So as I mentioned, I'm co-chair of the SIG. This is actually my 5th year being involved in leadership. So I held the research lead position for 3 years. Last year was my first year as co-chair working with Chus. So I'm really excited to kind of start my 2nd year in the position as co-chair. So in terms of who I am or where I work, I'm currently an assistant professor in the clinical psychology PhD program at Fairleigh Dickinson University. It's located in Teaneck, New Jersey. It's in the New York City metropolitan area. In terms of what I do and how it relates to pediatric integrated care, I've previously worked as a clinician in pediatric primary care, but in my current role, I really focus on student training, research program evaluation as it relates to integrated care. Recently, I was excited, became involved with 2 grants related to interprofessional training at the graduate level at my institution. So part of the grant is expanding practicum placements for our students, paid practicum placements to work in places like FQHCs. Some will be placed in schools. Really, the aim is to just increase access to care, particularly for underserved youth. Another aspect of this grant that I'm really excited about is the interprofessional training part of it. So at FDU, we have clinical psychology, we have social psychology, we have social work, we have nursing, an OT program, pharmacy, so on. So we're really excited to try to pilot a training program that brings all of these graduate students in the same classroom to learn how to work together in healthcare. So excited for those projects to come up. And finally, in terms of what I get out of the SIG, a lot of what I get from the SIG is I'm learning from others. So I take back what I learn. I bring it back to my students. We talk about integrated care. We talk about research. So it's helping me to kind of stay up to date and really just brainstorm and learn from others. So it's really been a great group. So that's my member spotlight. Let's have Amelia or Jonathan go next.
I can go next. Hey, I'm Amelia McClelland. I'm a psychologist at Community Health of Central Washington. We have integrated primary care behavioral health in all 5 of our clinics. I specifically work in our pediatric setting because Peds is my jam. I'm a school psychologist by trade, but love working in integrated care. I work in our gender clinic as well as our teen health clinic. So I work in both of those areas, and then we also have a family medicine residency program that's attached to our organization, and so they rotate through, and I work as a scientist practitioner helping to upskill usually in pediatric areas, since that's kind of an area where people have a lot of questions in family med. Kids I guess, are scary. So it's kind of fun to update our family med residents on how to work with kids, and then also patient-centered communication skills and working with LGBTQ plus populations. We also have our Seattle children's residents that rotate through with us for like 6 to 8 weeks. And so I get to work with them, which is really great. So yeah, I think one of the things that I really love about this SIG and working with everybody is just kind of like networking, meeting lots of people, learning all the amazing stuff that people are doing, and then learning how to steal it and implement it as well so that our programs can be just as awesome. And then also sharing what I've done so that other people don't have to like reinvent an entire wheel, right? They can just kind of like take something and go with it, which has been really great to be able to just kind of like work together and create some of those partnerships. So that's what I love about the SIG. Great.
Awesome. Thank you, Amelia. Can everybody hear me all right? I always want to check them out. Excellent. Well, so nice to meet you all. I'm Jonathan Larson. I've been a member of this Pediatrics SIG for the past few years, and this will be my second year serving as a research lead for Research Corner, where I present relevant research articles based on our topic of the month. As an aspiring future pediatric psychologist myself, I originally joined this SIG to learn more about the field in pediatric integrated care, and I certainly have done so in the process, met a lot of great people. I'm currently a fifth-year graduate student studying clinical psychology at Wichita State University. This year, I've been working primarily at an interdisciplinary clinic, a speech, language, hearing clinic with speech pathologists, occupational therapists, physical therapists, conducting autism and ADHD assessments for children. I previously worked in pediatrics at the KU School of Medicine. And speaking of our topic today, ADHD, I've actually been a clinician, counselor, and essentially sports coach for this adapted summer treatment program in an after-school format. And we just submitted a manuscript for publication, so hopefully that works out as well. What have I gotten out of this SIG? Yes. I'm actually a Wichita State person, but I'm all about KU after my experiences with KU. So let's see here. What did I get out of the SIG? I've learned a lot about the field of pediatric integrated care, from our guest speakers to our facilitated discussions. I also think that the SIG is a great way just to stay up to date on relevant research and other things in our field. And I would like to see the SIG continue to grow and recruit members from all ranges of experience, from student members like myself to experts in the field. So thank you.
Thanks, Jonathan. And actually, I think you're going to be up next for the Research Corner.
All right, excellent. I'll share my screen here. All right, so today we're going to be briefly reviewing an article on the variable patterns of remission from ADHD and the multimodal treatment study of ADHD. So to start, it is estimated that childhood ADHD remits by adulthood in approximately 50% of cases. That's been the notion that many have believed in. However, most research only reports on a single time snapshot of functioning, failing to consider longitudinal patterns of ADHD expression. So the authors of this study aim to investigate the extent to which children with ADHD experience recovery and variable patterns of remission by adulthood. Participants included 558 children with ADHD from the MTA study. The researchers used follow-up multi-informant assessment, parent, teacher, and self-report data to measure ADHD symptoms, impairments, treatment utilization, and comorbidities across 16 years, spanning childhood through young adulthood. And what this comes out to is 8 follow-up assessments ranging from 2 years after baseline with a mean age of 10 to 16 years, a mean age of 25. So from roughly 10 to 25, they tracked these kids. At each time point, authors identified participants with full remission from ADHD, partial remission, or persistent ADHD, which was defined as participants who met DSM-5 criteria for ADHD. As far as measures, all measures were used to assess ADHD symptoms, impairment, psychiatric diagnoses, and service utilization. There's quite a lot of data in this article, and as always, I recommend anyone for more specific data to please review it, but I'll try to highlight some of the main points that I saw. So here we have this case classification at each assessment point from 2 to 16 years after baseline. So first, the percentage of fully remitted cases range from 1.4% at the 2-year assessment to 18.5 at the 10-year assessment. As far as partially remitted cases, it ranged from 37.2 at the 10-year assessment to 51.4 at the 2-year assessment. As far as persistent ADHD, so those that continued to meet criteria for ADHD, that ranged from 39.7% at the 14 and 16-year mark to 55.9% at the 6-year assessment. For our next kind of data table here, we'll look at patterns of full remission, recurrence, and recovery from ADHD. 31.4% of children, or I guess later on adults, met criteria for full remission for at least one time point. Among the 175 fully remitted cases, 60% demonstrated full, so about half of the 60% demonstrated full or partial recurrence of ADHD after the initial episode of full remission. Recovery, which is defined by authors as untreated full remission of ADHD that persisted for at least 2 consecutive assessments, was detected for only 9%. And recovery, again, untreated full remission, the mean age was 25. And of that, 76.5% of untreated full remission occurred in adulthood, 21.5% in adolescence, 2% in childhood. 10.8% demonstrated stable ADHD persistent across all study points. And most participants with ADHD, 63.8%, had fluctuating periods of remission and recurrence over time. Here's another pretty crazy table, bar graph, line graph. So here we're looking at it's basically a bar graph that indicates cross-sectional estimates for persistence, partial remission, and full remission of ADHD. The line graph displays longitudinal patterns by each time point. So this green line here is the recovery. And this represents the percentage of participants who had experienced onset of recovery by the corresponding each time point. You can see recovery comes up here. Next, the red line is stable persistence. This line represents the percentage of participants who continue to demonstrate persistent ADHD. The yellow line, stable partial remission. Pretty self-explanatory, that one. And the blue line is fluctuating status, which indicate at least 2 changes to cross-sectional classification since baseline diagnosis. So this kind of, again, fluctuating, waxing, and waning there. So as far as a lot, I know that was a lot, but as far as the overall conclusion, most cases demonstrate fluctuating symptoms between childhood and young adulthood. Although intermittent periods of remission can be expected in most cases, 90% of children with ADHD from the study continue to experience residual symptoms into young adulthood. So what does this mean? The main implication: providers should expect recurrence of clinically elevated ADHD symptoms and impairments in most patients who experience remission. Therefore, continued periodic screening for recurrent symptoms and impairments should therefore be standard practice after successful treatment or remission. All right, thank you.
Thanks, Jonathan. Really interesting data. I think really highlighting the chronicity of ADHD. So, and I'm sure we'll be able to talk a little bit more about it. But without further ado, let's jump into our presenter today, who's going to kind of talk more about ADHD and the chronicity and how we can treat it in pediatric primary care. So we have with us Dr. Austin Burns. He is a fellow, integrated primary care, pediatric primary care fellow at Nationwide Children's Hospital. And he's joined us today. Thank you.
Yeah, thank you for having me. I'm really excited to share this. It'll be partly sort of like this is how we do it and also how we can do it, maybe. So a little bit of both, I think, pieces included. Let me just take a second to. Hopefully everyone can see the slides. All right, great. So that's okay. We're going to be sharing today about potentially some potential ways for how we can provide, strong evidence-based care for ADHD over the course of the pediatric lifespan and preparing for adulthood. And so I wanted to start with this quote from James Clear, where he talks about, the idea that you don't rise to the level of your goals, you fall to the level of your systems. And I like this quote because I think it shows, we have these goals, right? I think everyone probably has the goal of providing the best evidence-based care that we can for our kiddos with ADHD. And if our systems aren't there to support that, then we're gonna likely fall short. And so as we talk about, some of these systems today in the presentation, I just want to emphasize that. So I wanted to start here by just sort of giving a snapshot of this is essentially kind of how a lot of integrated primary care clinics might be looking at ADHD now. So this is kind of the here we are at this point, how a lot of places are doing it, what it looks like, what's the effectiveness and all of that. So in this Shadula et al. Article, they looked at a systematic review across a lot of existing integrated primary care models and how they were addressing ADHD. And they found, across these models that in general, participants or patients first had a greater response to treatment, both medication and behavioral intervention. They had greater reduction in symptoms and also in other domains of functioning and impairment, such as behavior. When psychologists were integrated, the behavioral treatments themselves tended to be more accepted by physicians and families when they were provided through an integrated psychologist or behavioral health provider. And then there was access to behavioral health treatment was increased because it was more available to these patients in the term. So that's a good snapshot of, how we know what we're doing now is helpful and effective. And I think that there are a lot of specific ways that we can kind of improve upon that to provide even better care for these families and youth. And so the idea of, what are we optimizing for in a model of ADHD? And so I think that, primary care management of ADHD should optimize for three things. The identification of ADHD symptoms and the associated impairments. I think that it should optimize for equitable access to appropriate evidence-based interventions, including behavioral health services and medication. And then it should optimize for the chronic management of ADHD symptoms and impairment over the course of the pediatric lifespan. And so we're going to dive into each of these components a little bit as we go. So this list probably isn't surprising to anyone. This is a lot of the associated symptoms and impairments that are used with ADHD experience. So things like oppositional behavior, big emotions, difficulty with peer interaction, family conflict, peer conflict, risky behavior, sleep mood, all of these concerns, many of which aren't necessarily directly targeted by medications alone. And so we'll talk a little bit about, why the sort of value-added piece of behavioral health services when it comes to addressing these specific areas. And one study that I like to highlight when I talk about impairment and symptoms as well is this study from O'Connor et al. Because they looked in a primary care setting, they tracked, the improvement in symptoms over time as well as impairment. And so these patients were utilize medication only to manage their symptoms. And you can see the dotted or dashed line, those are ADHD symptoms. One of them, I can't remember which, is inattention. The other one is hyperactivity. And so we see kind of a decrease and then a steady improvement of those specific ADHD symptoms over time. However, if we look at the solid line, which is the impairment of, well, either writing, relationship, organized activity, this is a snapshot of the impairment that they are measuring, but they all kind of look the same, where we have a relatively high, consistently stable level of impairment. So even though the symptoms are improving, the impairment or the way that these symptoms are impacting these patients is still there and still existing at the top of the quality span. But if we think about the very first slide when I shared, we also know that when we include behavioral health providers, psychologists in the treatment, that we do see improvement in these other areas. And so optimizing for identification of symptoms and impairment, I think looks like an initial evaluation process that includes joint visits. So where there are behavioral health providers who are also have a role in the evaluation to provide another perspective, to ask certain questions, maybe more specifically about impairment and how it's impacting the family. And then, of course, using evidence-based questionnaires that, most places probably are, Vanderbilt, something like that, that capture those impairments and the symptoms over time. But then also, including specific, in those clinical interviews, specific parent and child goals, right? So not necessarily just symptoms and impairments, but what are they hoping to improve upon? In this article that's cited here actually shows that a lot of times the goals that parents and kiddos have for treatment for ADHD it's not necessarily I want to focus better or I want to be less active, right? I want to have friends. My goal is to be able to, do well in school. My goal is to be able to participate in after school activities and not get those things. And then the last point here, I think in identifying symptoms and impairment includes the reassessment of these impairments and symptoms over time, right? So we just saw the article that talks about chronicity, and we're going to talk a lot more about that in this presentation as well, but just thinking of making sure that we're continuing to figure and that we have those followers. So the next sort of part of the, what we're optimizing for here is equitable access to evidence-based treatment, right? And so in general, we know that behavioral health services, at least existing and are hard to come by. They're, we have a hard time meeting the need. And so this article looked at or found that, roughly 16 to 17% of children in the U.S. Have at least one mental health disorder, and about half aren't receiving the treatment they need for these mental health disorders. We also know, right, here again comes integrated primary care. We know that integrated primary care does a good job of helping to address this, right? It can provide greater access to behavioral health services, and when they're provided, they are generally effective. They are helping improve the lives of these kids. We also know that this can vary across patient backgrounds, right? And so thinking of, what disparities exist. So we know that patients of marginalized, racial and ethnic backgrounds are less likely to access health services generally. This is also true for behavioral health services broadly. And it's also true for specifically, I don't have it cited here, I think it's later, but for ADHD services as well, right? So we also see, right, that integrated primary care can help reduce the disparities across access to behavioral health services. Although there's still, certainly plenty of work that we can do now to close that gap. And then here's the ADHD specific points, right? So if we narrow in more to beyond, all of this behavioral health, but ADHD specifically, we know the gold standard treatment is a combination of medication and behavioral health services. And we also know that access to behavioral health or evidence-based diagnosis and treatment is inconsistent across primary care clinics, across primary care networks. And that only, even less than a third of families report receiving behavioral health management or behavioral health support for ADHD. whereas most families that have received support for ADHD do report having that big jump on that. And then I kind of already shared this. We also, there's a lot of evidence that suggests that families of marginalized racial and ethnic backgrounds are less likely to get food services. I think it's also important to highlight that there could be some specific ADHD related factors that can lead to their own disparities or inequalities in terms of how behavioral health is accessed. Parents of children with ADHD are more likely to have their own psychopathology compared to other parents, and this includes having ADHD themselves, right? So very big genetic component to ADHD, and so those families might have a harder time being able to manage multiple appointments or to make it to places on time and all of those things. So that's just one additional barrier that these families might be experiencing, as well as ADHD related stigma. It still exists out there in the world, and it does have an impact on treatment follow through and how we come back and access food with the health services. And then, through some studies that have looked at integrated primary care, again, here we see, right, integrated primary care can help increase access to ADHD services with the food, including behavioral. And so when we're thinking of, optimizing for equitable access to appropriate evidence-based interventions, what could that look like? So again, I think, there's some magic in having some intentional joint visits where behavioral health providers are sort of almost automatically included in those ADHD follow-up appointments, right? And I think that there are two things that I think would be helpful in these appointments. And, I think it's important to provide some sort of general foundational interventions and education to the family. What is ADHD? What are some basic behavioral strategies for managing, whether it's, praise using, natural consequences and natural rewards, maybe it's even, how do we build a routine, even though that this was going to thrive in routines. Also, some general education about navigating school supports and medication, making decisions about medication. But then also, some specific interventions related back to what those families go for, right? What did they want to see improve upon, and how can we make sure that if we're only going to see them for 2 to 4 visits, how are we going to make sure that we're targeting those specific goals that families have, right? And then of course, appropriate medication titration is a big component of this. And then I think that it's also important for any model of care for ADHD to have a place for those kiddos and those families that might require a little bit higher care when in the right? So thinking of, is there something like a complex ADHD pathway or something that can be included that's still within the primary care system and maybe a co-located type of model where they can come have longer visits with behavioral providers to really break down some of these, behavioral threats, or to do maybe longer types of evaluations if there's some factors that might be complicating the time. And from there, I think we move on to the last piece of the puzzle, which is, how do we work to manage ADHD as a chronic condition, right? We saw the evidence today that around 60% of individuals have persistence into adulthood, almost have continued to meet criteria for ADHD into adulthood. And what I think is a particularly interesting finding from the article we discussed today is that that pattern of what seems to be, remittance of ADHD symptoms and then reoccurrence. And that I think provides good maybe rationale for the use of integrated care to follow these families across time and to maybe be intentional about how we're including behavioral health services at key points. And we'll talk a little bit about that as well. And when I look at the idea of ADHD over the course of a lifespan, I like to look at this. I like this graph. This was something that has been circulating through my grad school lab forever, and this is kind of how we conceptualize it. And so I think what's important here is we're seeing that over the course of someone's life, functional management, right? So we go from you know, cutting and coloring and kindergarten to, you know, all the way up to middle school where now we have new teachers, we might be switching classes, we're juggling a lot more homework, and then now we're in high school. All of the testing seems to be really, really important, and maybe I'm also getting a job. There's all these functional demands that are continuing to be placed upon me, you know, everyone, but especially maybe difficult to those with ADHD. And at the same time, we tend to see the sort of the support resources start to increase over time, right? And you especially see this right at the end of adolescence when you know, we're leaving high school, maybe going to college, maybe entering the workforce, where none of those supports are guaranteed to us anymore, right? If I want extra help on homework, I need to go to the disability services office at my college and ask for it. Because no one is going to come to me to try to provide that. And so as those support resources start to decrease, sometimes folks with ADHD aren't sure how to navigate those scenarios, right? And I think that we can do a lot of work in the primary care setting to prepare with ADHD for these types of transitions that are happening, and prepare them to be successful in those environments, right? And so, and I think that this is in part why we sometimes see, you know, sometimes symptoms can seem to appear in ADHD, right? There are cases where maybe there are a few symptoms early on, but they don't get in the way, so it's not really brought up. Someone becomes an adolescent, now they're expected to do all of these things in high school, and they don't have as much support, and they're like, what the heck is going on? I feel like I'm starting to fail and falling behind, I can't focus. And so that's something that can happen in adolescence. Also, we know that we tend to see a shift, right? ADHD starts to look a little bit different. You know, it's not the hyperactive kiddo running around the classroom anymore, right? We tend to have, as we shift into adolescence, we see less hyperactive symptoms, and we tend to see more inattentive symptoms. But those hyperactive and impulsive symptoms that do exist also tend to shift and look a little bit different, right? So it's not the kiddo that's running around the classroom, but maybe it's the teen that's in class feeling restless, right? It's just feeling a little more jittery, that you kind of feeling. Or instead of leaving their seat or standing next to their table or walking around their table, maybe they are making excuses to go to the bathroom more often just so that they can get up and move. Or maybe they're moving to the back of that bathroom, right? So we start to see, you know, the presentation of these other hyperactive impulsive symptoms started. And then there are some, you know, areas of impairment that are relatively unique to teens with ADHD, right? So a lot of peer rejection, victimization, difficulty with intimacy, and less satisfaction in romantic relationships at that age, an increase of risky behaviors, substance use, risky driving behavior, and then of course, you know, the cycle of disturbance with sleep that can keep us with ADHD and ADHD symptoms. And you know, of course, I know here that these aren't necessarily only experienced by teens, but I think that they're particularly big, especially. And so we're thinking about optimizing for the chronic management of ADHD symptoms and impairments, thinking about it over time. Again, I think relying on some joint visits. So coming back for those ADHD follow-up visits, they're going to talk to their doctor about medication and any adjustments that might be made. And also maybe a behavioral health provider, right? So that they can provide some services at that key transition, those key transitions like school transitions. So there's some evidence that shows that adolescents sort of entering middle school have a spike in ADHD symptoms. And so if that's something we know, then maybe when we know that our you know, patients are about to enter middle school, maybe that's a good time to check in and say, hey, how are you planning on managing your work, right? Have you ever used a variable, right? You have ideas on like what's helpful for setting up a homework area for yourself, those types of things. Just to sort of try to, you know, be a little bit preventative and have them have a more successful visit. Also when they're about to drive, right? So there are a lot of really good strategies that we can explain for with ADHD to be safer driving, right? Then there's also chronic self-management. So are we providing or ensuring that we're providing the teams youth kind of across the board with education, or do they understand ADHD? Do they know, you know, how it impacts them? Do they know, you know, when there might be times like that it's important to take medication versus times when it's like, probably okay, you don't need to take it today if you don't want to, right? Or are they able to identify things that are helpful to them? Do they know that, okay, this is the time of day that I can focus back, or things like that? So do they have an understanding of how they can help themselves over time? As well as, I think this also includes like what are the what are the resources available and how to access them. And then follow-up visits for medication management, of course, right? Where we're checking in on how the medication is working, and we're reassessing impairments. Our Medicare places already are doing in terms of further medicine. And so one example to kind of see how maybe joint visits could be utilized at these transition areas, ADHD and driving. So ADHD symptoms are associated with increased driving risk. This has been fairly well established in the literature. There's also, evidence that changing the family climate, so how the family communicates openly about driving, how they show their commitment to driving safely, how they provide feedback for driving and driving errands. These can all lead to improved driving outcomes with ADHD and then sort of mitigate that risk that exists with driving. ADHD and driving outcomes over time, right? And so that's a good point where maybe medical providers, behavioral providers can talk with the family. And how are they talking about driving, and how do they feel their parents use their support, do all of these things to help create an environment where safe driving is effective and up. Another one that I think this is one of those things, again, if this looks familiar, please tell me, but this has been circulating around my grad school sort of lab as well, and I have no idea where it came from, but I think it's a good start to what a checklist could look like for helping someone build their knowledge and education over time of, understanding ADHD and sort of their medical history, right? So starting early with, do they know what ADHD is? Do they know the names of their medical, right? And then as I get older, can I share parts of my medical history? Do I know, when someone asks me that question, that I know how to update them, or I know what's important to share? Or do they understand the risk? Do they know what happens if I don't take my medication? These are things that could happen if I do take it, focus better. This is maybe particularly important around that, right? But then also, again, do they know what happens when they turn 18, right? Do they know what rights they have now that they're 18, also those abilities, and the resources that might be available to them when turning 18? And so using this as maybe some kind of, guideline or something like this to help making sure that we're providing them structured information about help them learn all of these things. And we know that oftentimes with folks with ADHD, you can take repetition, right? And multiple people sharing this information for them to really, get it and be able to communicate it. And so kind of bringing it all back together, right? Seeing that primary care management of ADHD should optimize for the identification of ADHD symptoms and impairment, should optimize for the equitable access to appropriate evidence-based interventions, including alternative identification, and then should optimize for the chronic management of ADHD symptoms and impairment. And I'm going to stop sharing and then and I'm happy to answer any questions or provide any reasons.
Yeah, it's wonderful. Thank you so much, Austin. There's already been lots of comments in the chat about how great this presentation is. So let's open it up to comments, questions that people may have.
It's taking me too long to type. Is it okay if I just ask the question?
Absolutely.
Yes, please.
Okay. So I am curious because I know, I know there were various approaches, and it honestly depended in the clinic that I was working at in Detroit. It really depended on which attending was guiding the discussion. And when it came to ADHD, some were phenomenal at it and others really struggled with it. But one of the things we came across was it's different conversations depending on where in the developmental process they were diagnosed. So if we were dealing with a 4-year-old, which was unusual, but still happened, versus a 16-year-old. And at first being diagnosed at 16. So I am curious to know if you have anything, or if you, how you handle guiding those conversations. Was it something kind of like this checklist that you had that you started with, or like, how do you do that?
Yeah, no, I think that's a good question. I think usually, I'm glad you bring up that point too, that it really matters. And I think having something like that, that checklist could be helpful. But, I tend to think of how am I always starting with, regardless of how old, or when the diagnosis is happening, the first piece is providing a good understanding of ADHD of life. And I think that sometimes that can mean, for example, if they're a teen, they probably can tell you a lot of how these things are impacting them, right? And sometimes I think being helpful to provide, like, yeah, the reason this is happening for you, like, that makes sense. A lot of teens with ADHD tell me the same thing, and maybe I can identify, depending on how good I'm feeling that day, right? I can say, it's because your brain is doing this, right? Or we think that it's because your brain is doing this, or something like that. For younger kids, or when something is happening there too, I try to relate a lot of that information to the parents, right? In terms of, like, this is what you're seeing. These are the things that are maybe driving you crazy, in terms of, interacting with your kiddo. And here are some reasons why those are happening, right? And so I think, I don't know if this is answering your question, but I think I always start with that really strong piece of, the conversation always starts with, like, understanding ADHD, in terms of, like, how it's impacting the kiddo at whatever that age is. So if it's a teen, it's maybe getting more of their impact of how their input of how it's impacting them. But if they're a lot younger, then maybe it's more about, how these are impacting, or what impacting what you can be.
I like that you brought that up too. The part about getting more input. Like if they were older kids, like 12 and up, sometimes a little like 10 or so, if depending on the kid presented, but having them fill out a Vanderbilt too is like cross off the parent part and put patient, so they can tell you what they're experiencing. And the other reason I asked was because I noticed that depending on the level of emotional regulation, for some teenagers, when they got diagnosed, it was oh, thank God, I know what's going on. And the other one's like, oh my God, there's something else wrong with me. And they went right down the rabbit hole. Yeah. And it just is so individualized.
Yeah. And I think too, when there's a lot of the emotional dysregulation pieces, and there are all these other things that might be coming along with it, certainly oftentimes ADHD is something that is likely contributed to a lot of those, feel like the pattern of failure over time, and the depression and things like that too. And sometimes an explanation like that can be helpful, once the initial, sort of emotional reaction happens.
Thank you.
I don't know if you saw the question in the chat that says, if a child is stable on medication, how do you anticipate the possibility of lowering medications, or how do you know a remission might be occurring? Maybe you can speak to that question.
Yeah, that's a really good question. I don't know if I have any actual, like, really intelligent, specific thoughts about that. I do think that, especially, I know that we see a lot of the remission starts to take place as folks get older and can have more input in terms of, like, I feel like teens can be, a lot of teens, not often, a lot of teens can be really insightful in terms of explaining to you, like, how much they think the medication has, especially if they're kind of still. And I think having conversations with them too about, like, even just the idea of knowing, like, hey, I'm glad that you're feeling really great, and you don't think you need to take this medication anymore, and 8th grade is going super well, and you're like the top dog at the middle school, and also next year you're moving to the high school. So, I'm wondering if we can, just talk a little bit about that, right? Like, what are some anticipation, like some things that they might be anticipating could be more beneficial in high school, but also some things that might be harder for them, right? And making it more of a two-way conversation. And I think that I'm obviously not a prescriber of medications, but I think one good thing about ADHD medication, especially once we kind of have one that we know has been helpful to someone, is that it's okay if we stop and then we want to restart later, that's great. Yeah, I think that could be maybe a helpful tool.
I know that we are unfortunately at time, but Austin, I wonder if we could, if people have any other questions or comments for him, to shoot him an email, and we'll share that email if that's okay.
Yeah.
Otherwise, thank you so much for your presentation, very informative. And thanks to everyone for attending our first meeting of the year. And we look forward to seeing everyone moving forward.
Thank you.
Thank you. Bye-bye.